I see our numbers are limited today. Where's
Like I said, I truly believe this viral, whatever thing's going around, it's getting a lot of us.
oh
So it is.
oh then why aren't they more online?
April 12th, approximately 11 o'clock.
Pardon me?
So it's going to get me on April 12th.
Probably 11 o'clock. I hear you. You know, it drives me. I
Like I said, listen, I don't get sick, and that's an issue. Because like some days I'm like, hey, I don't want to jump in class. I want to feel sick, and I can't. My body refuses to get sick.
well, I'm glad to being not being sick is a good thing.
Yeah,
All
that's
right.
it, like,
Let us begin. The sooner we begin, the sooner we can conclude. I know you're all in on that. Why? Oh, God forbid. What a difficult. When does lab start? At 12? That is, yeah, you don't get much of a break. I know. Yeah, that's right. I nor should you. All right, we're go. Hey, thank you. I know. I mean,
you're fired up this morning. Pirates are winning. You're happy.
I am not having a great time. My car is.
Oh.
I believe we're sitting shiva for my car. Sitting shiva. You know what that means? In Judaism, when somebody dies, you spend 7 days. It's not a mourning period so much as you're trying to sort of bolster the people. So you sit for 7 days. You have prayers typically twice a day, and a lot of food. It's the important part. So it's we do it. We plant fast.
Is it a,
Boom,
is it a
in you go.
bad diagnosis? Bad diagnosis.
It is. I think it's terminal.
Oh no.
240,000 miles. If something goes wrong, it's what can you do? But I digress. Moving on. So this is where kind of we left. I did want to reiterate the importance of transport maximums. Okay, and particularly for glucose, that's the big issue because as the transport maximum is continually exceeded, it lowers the maximum by damaging those transporters. And and unfortunately, this is one of the big problems why it's so imperative to aggressively control diabetes early on. Again, to reiterate this point, most of the resorption, 2/3 of it effectively, is pretty much done in the proximal convoluted tubule. And again, some of the stuff is absorbed to create gradients to get rid of. We're going to spend most of the day today talking a little bit about the loop because that's where that's really about concentration, and that's particularly in the juxtamedullary nephrons and the vasa recta. It's a very unique system. You don't see it anywhere else in the body. Okay, so we have a thin descending limb that's permeable to water and a thick ascending limb that is impermeable to water, but solutes can move. And you're going to see that there's a lot that goes on there. And then again, I talked about this a little bit in the distal convoluted tubule and the collecting duct. In addition to secreting, this is also where the impact of antidiuretic hormone and aldosterone is utilized, and the importance of it being able, the antidiuretic hormone when necessary to strictly retain water, and the aldosterone, which conserves sodium and in water as well. So basically, and it's always the same thing, sodium coming in, potassium going out. So that's some of the impact when we used to treat a lot of folks with agents that impacted that particular region, things that were trying to impact aldosterone or work against it. We end up with a lot of problems. They started to develop a whole series called potassium sparing diuretics. And what they did is they limited the amount of potassium because people were getting very, very low potassiums. And that's more critical. Sodium, you got a lot of wiggle room. Potassium, you don't. So there, and again, that was where most of pharmacology was way back then. So now with the advent of agents that interfere with the angiotensin, renin-angiotensin pathways, and with calcium channel blockers, it's made the treatment a little bit more useful. As you can see, without aldosterone, we would eventually be incompatible with life, even though we have a lot of sodium, so to speak, to play with. One of the areas that works, as you know, from the overload is when there's too much pressure and stretches the atria unnecessarily. That's when it generates something that's named for what it does, atrionatriuretic, which means you spill sodium and then the water follows it out. Okay, cardiac atrial cells if blood volume or pressure is elevated. And then parathyroid hormone, again, distal convoluted tubule and calcium resorption. So it's a nice little summary chart. It's there, and they summarize it some more here and more here and more here. So occurs almost completely in the proximal convoluted tubule. It's that distal convoluted tubule where it's sort of like finalizing what's going out. Potassium, hydrogen, so it's acid, potassium ions, acidic ions, ammonium, creatinine, etc., etc. Okay, even things like that bicarbonate to neutralize it is there. So this is where we get rid of a lot. That's why the urine is so important. And again, it's easily acquirable. It's a convenient way to, even though there's a fair amount of false positives with metabolites, dipsticking the urine, usually, it's the old story. When they're looking for either drug agents or even performance enhancing drugs. In sport, you have two samples typically from the urine that's collected, an A and a B. The A is dipstick, which is not 100%. The B is then subjected to more rigorous scientific testing in order to establish whether it was a false positive or not. So, for instance, and these are well known because opiates are derived from poppy. If you eat a lot of poppy seeds in whatever foods, that can give you a false positive. That things like that are there. Certain agents can generate false positives for, and it was much more impactful with marijuana, with cannabinoids and things like that, like higher levels of ibuprofen. Sometimes we give a false positive. It's a little more forgiving now because we're a little less crazy about that. Unless you're in a field or in a drug-free workplace completely, or in a field where they test frequently. Just saying.
Yeah, I gotta get drug tested for my internship.
I think healthcare.
Yeah, healthcare for sure. Those are it's part of these days. And I had this discussion with my son the other day. I think it was yesterday. Is they're retesting people more frequently, not just for drugs but background checks, because it's somebody wants to stop you from doing something terrible after your last background check that they won't necessarily pick up. Conceivably. So nowadays, insurance companies are so. I think a lot of this has been spurred on when we see them with these train derailments, things like that. That a lot of companies, it's not so much the companies, their insurer says, we have a new policy. You have to background screen every year, every 18 months, whatever it is. So don't get excited about the same thing for testing that you have wherever in the workplace. It's the way it is. So all of those things that are there, undesirable substances that were passively resorbed, excessive potassium, which mostly due to aldosterone, pH management, which is something we'll talk about a little bit more in yet another unit. And this is the concentration nugget. There's two systems. I had done this more elaborately than I will do it with you, with the MCAT students, because it's probably more likely to be a topic there. Because it's one of those complicated areas in medicine and science that you start to look at. Effectively, it's called the countercurrent multiplier and the countercurrent exchanger. It's a continuous system that allows for urine to be adequately concentrated. It's only in the juxtamedullary nephrons, and it has to do with those long loops, the vasorecta, surrounding those long loops of Henle, and the fact that fluids are flowing effectively almost in opposite directions and making hairpin turns. And when you have a system like that, you can establish gradients over time. It starts even before you're born. But when you're born, anybody who's had, younger siblings, anybody who's babysat, we all know and changed a lot of diapers that there's a whole lot of urinating going on. That's because this mechanism is not well established until later. So by the time when kids are able to no longer have to be diaper bound, if you want to coin a term for that or have to use diapers, when that situation occurs, it indicates that this mechanism is probably much more functional. And so too, obviously, as people become incontinent later in life, it's the old thing, the very young and very, then this system begins to fail a little bit. You can look at it that way fairly easily. And it's all about osmolarity. So the typical osmolarity ballpark, 300 milliosmoles. It's very hard to, and we've talked about this, to be able to tell what's in it because there's different things in the interstitial fluid and the cytoplasm and cerebrospinal fluid. They're all, relatively speaking, osmotically equal. They just have different constituents. Interestingly, the way that you're able to tell if something is osmotically the same is by its physical impact. So they use freezing point a lot to be able to determine it. That's how you're able to determine that normal saline and D5W and Ringer's lactate could be substituted. Because the whole story, when you add something, it's going to alter those physical properties that are there. So they talk about it in different types. I'm not going to go into it. So the beauty of this is the kidney, if it has to retain fluid, if you're dehydrated, it does more. And this countercurrent mechanism or countercurrent multiplier is where this is. So fluid in opposite directions, two adjacent segments with a hairpin turn. It's exactly the long loops of Henle, and it has to do with long loops of the vasa recta that sort of surround those areas. So the multiplier, interaction of filtrate flow in the ascending and descending limbs, and the exchanger is able to maintain this gradient, this osmolar gradient that has developed over time and contain it. So they work together. So when it's established, this gradient runs roughly from normal in the cortical level, and at the very tip, sort of the apex of that pyramid, that pyramidal structure, it's 4 times as concentrated, 1,200 milliosmoles that are there. So it creates that gradient, and then in doing so over time, what preserves it is the exchanger by continually exchanging reabsorbed particles so it doesn't change over time. I'll talk about it a little bit without getting too much into it. And so this is how we concentrate urine. When is it most active in you? When you're sleeping, because that's when your kidneys are most active. That's why we use first morning urines, whether it's pregnancy testing, whether there are certain lab tests that have to be done where they want that to be. Sometimes it's just as easy to do it randomly, And so when I go, and unfortunately, again, my urologist and I have such a special relationship. I didn't share this. I've shared it with Dr. Badger and Dr. Hillwig and Dr. Buxton because we all work together with the MCAT. But apparently, after all's been said and done with me, I've got to guys have another procedure or two. It's something that happens from all the chronic irritation and all the stuff that's been done. I have a kind of a stricture, so it's tough getting out, so to speak. So the moral of the story is don't smoke.
Gotcha.
I'm watching you. I got
asthma. My lungs can't already do anything.
But I'm still watching you. None of that wacky tobacco.
No, I can't.
Wacky tobacco. What?
That was an old
Did they
term.
ever take like super tobacco or something?
No, wacky tobacco would be marijuana back in the old days.
Oh.
The smallest drug tested me, so good.
We'll see.
I'm good.
We'll watch. Moving on. So here, this is kind of gives you an idea what the gradient is like as you see it here. So the nephrons create this gradient and it allows the kidney to do it. So they go through it. The gradient is there, and that's sort of the big picture look. And you see at the same time, the vasa recta, which you'll see as they describe it, preserve it. So I'm flipping through the slides relatively quickly because I don't spend a lot of time with it. It's more important that you know what they do. And so here it comes. Filtrate flowing in opposite direction. So it's about the filtrate. It's about the permeabilities. That thin loop descending very permeable to water. As you get down to the lower reaches of the medulla at the bottom of those loops, it's 1200 milliosmoles. It just sucks the water right out of it. Okay, now that's the good news. The bad news, when it comes up, now that filtrate has minimal water and, relatively speaking, a much higher concentration of solute. So in order to maintain that, in the upper portion of the limb, the ascending limb, where it's thick and not permeable to water, in order to balance it out, you're able to exchange for sodium and chloride, do a lot of active exchanging. So it maintains it over time. You're going to see the areas between the regions and the concentration of the filtrate. Typically, once it's developed, average about a distinction of about 200 milliosmoles. And what happens eventually, it's such a powerful mechanism of the exchanger that by the time the fluid gets around to the distal convoluted tubule and the collecting ducts, it's actually hypotonic. So it's not, they've put enough fluid back in there, relatively speaking, or removed enough solute, relatively speaking. So now, and urine comes out normally hypotonically. So they're not in direct contact, but close enough to influence each other because of that hairpin term. So they're paralleling each other. And that's all. So in the ascending limb, it's impermeable to water and selectively permeable to solids. So sodium and chloride actively resorbed, even some passive resorption in the thin segment. Descending limb, about water. Impermeable to solids, but water passes out of that hyperosmotic. And so it causes remaining filtrate osmolality to increase. So that inside the loop, we're at 1200 milliosmoles because that water's been sucked out. Now, the more sodium chloride the ascending limb then actively transports out into the interstitial fluid, the more water diffuses out in the descending limb. The more water that diffuses out of the descending limb, like I said, the saltier the filtrates of the ascending limb, then uses that salty filtrate to further raise the osmolarity within the interstitium outside of those loop areas. So here's the 200 milliosmol between the two limbs that are consistently there, and between the two limbs and between the ascending limb and the interstitial fluid. And I'll show it to you a little bit. And it really just what you have to know about it. Water leaving, and then to balance it out, salt leaving, water leaving, balancing out, salt leaving. So it's a continuous process that occurs. These are the distinctions that you can see. So you're always seeing, if you compare the descending limb to the ascending limb, it's always that distinction of about 200 milliosmoles. Okay. And pretty much other than when you're getting to the hairpin itself. That's there. So water moves out of the filtrate in the descending limb and then reaches its highest at effectively the loop. And then the sodium and chloride are pumped out. That's active transport. There's a lot of energy. So there's a lot of blood supply. And so this is the transition between the vasa recta being a true capillary bed, starting with off of an arterial, and then the oxygen in it being used to facilitate the active transport. So you end up with venous blood. Happy days. Love that. Let me go so fast. Filtrate at its most dilute as it leaves, even to the point of being 100 milliosmoles. So that's really hypoosmotic. The exchanger, highly permeable to water and solutes. Those are the blood vessels. It's also countercurrent. So the blood can exchange with the surrounding interstitial fluid as it moves. It remains isotonic or isoosmotic with the surrounding interstitial fluid. The vasa recta is able to resorb water and solutes without undoing the aforementioned gradient, which could be being created by the multipliers. It's a beautiful system that works together. It's one of the most difficult things. I can recall to this day when I was still a student, in that summer between my junior and senior years, watching one of the interns, first year, because in the old days we just had a blackboard and like in the room where kind of you hung out in between cases or talked about stuff. Yeah, and he's drawing on the board. He's doing that whole thing just to try to analyze a patient with problematic kidneys. It turned out that the attending on that service was a nephrologist. I was lucky; mine was a diabetologist, so I got more diabetes out of it. It's one of those areas. So that's what I'm fond of saying. The nephrologist, cardiologist, oncologist, those are, we call them doctors. Those are the smart doctors. Take it from me. There's a lot of not as smart doctors as you like. Even ones who don't give antibiotic drops when they should. Rise. Don't tell. You didn't hear that from me.
I didn't hear anything.
My foot doctor instructor is telling you what to put in your eye. Sorry. Tell him you heard a little bird told you. My mom and dad used a little bird told me. You put up some squawk. Okay, so rapid removal of salt. This is the exchanger. Removes reabsorbed water, so it preserves it. Water in the ascending area of the vasa recta comes from descending vasa recta or is reabsorbed from the loop. So the volume of blood at the end of the vasa recta is actually greater than the beginning. So what you're doing basically is eventually you're bringing fluid. Remember, we had filtrate. Okay. And so we have to reabsorb that filtrate so that the blood going through the vasa recta and those juxtaglomerular or peritubular capillaries, that's fairly thick. It's got to absorb a lot, less so in the cortical area than in the medullary area. So they're just showing you that how it preserves it. So now it can be used without the gradient. We wouldn't be able to raise urine concentration or conserve water. So if you're having overhydration, you won't have to utilize antidiuretic hormone. If aldosterone was present, you can even reduce it even more, make it more hypoosmotic or hypotonic if necessary. So we really do a good job at adjusting fluids and with the secretion of hydrogen ions, maintaining pH. And it's as long as that system is working, it's really a wonderful system to balance things, getting rid of toxins, maintaining sodium, potassium, chloride, bicarbonate levels, all those important electrolytes. So if you're someone who's dehydrated, and we all have been so, you're working outside, you're doing physical activity, it's tough. Imagine, and maybe it's happened to you guys after a workout, particularly if you're in sport, when they want to get a urine sample right after you've done your practice. Not so easy, you know, things like that. And there's some issues with all of that. Why do they do random testing for the most part? Because if they have fixed testing, there are certain substances that metabolize quickly. When cocaine was and I don't know if it still is or not, when it was a very, very popular drug, particularly so in the 80s, and they kind of play ping pong with these drugs. Those amphetamines, they go 2 to 3 days, they're gone. Okay, so that's why you do random testing. If you every Saturday, every Monday, well, you stop on Friday if you're able to. Not everybody can do that, obviously, when they're addicted to things like that. So voila, and so most of the volume is going out. It's fairly hypoosmotic, and they just go through this. Urea also plays a role. It enters the filtrate in the this is why you take it and secrete it back out in the ascending thin limb of the nephron by facilitated diffusion. Okay, reabsorbs water, leaving the urea behind. The now highly concentrated urea. Okay, so you can see what's happening. Enters the filtrate ascending thin limb, the upper portion of the thin limb, and by facilitated diffusion, and then if the water gets resorbed over time, deep now you have that concentrated urea, and then it can move back in the ascending portion of the thin limb as well. So I think they meant urine I would say when they talk about this moving back in and moving back out, so it can move into the filtrate and back out of the filtrate just as well. And this is what we use for so long. Certain things are inherently diuretic. Okay, ADH inhibitors, alcohol's poster child, and that's one of the issues with alcohol. And it's got a lot of issues therapeutically. That's a big one. Okay, because that also indirectly impacts the clotting mechanism. That's why we utilize, like my first wife had the genetically made DDAVP, which was the vasopressin that was made because she was short on certain clotting factors. Sodium resorption inhibitors, okay, caffeine or drugs for hypertension or edema, okay. So they interact with that, and so what you're trying to do is you're trying to, by not allowing sodium to be resorbed, it goes out, the water follows it. Loop diuretics still used a lot. Loop diuretics interact with that gradient. The most famous of those, surely, and for any of you going into a medical field or medical related field, we use it a lot to get fluid out fast, called Lasix. That's the trade name, also known as furosemide. And it's used mostly in hospital, and we do it a lot in catheterized patients. So you're really trying to, sort of, tap out and get a lot of fluid out. And you have to watch it. Because my dad was, in those days, it was very limited. They basically, when they had people with high blood pressure or heart, they used digitalis alkaloids and lace, and both of them tended to make real imbalances in potassium. So it was really a concern. I went to approach my dad's doctor about that. He didn't like that. But I digress. I wasn't a doctor yet. This is my dad. Yeah. So this is the osmotic aspect. So we know about the great thirst. Substances not reabsorbed. For example, the diabetic, and there's plenty of things that act as osmotic. Sometimes we use them therapeutically. We give people something like that because we want to try to force them to unload that are there. And like I said, it's so easy, not just for illegal substances, but it's the best way to assess its function is, again, nitrogenous waste materials, blood urea nitrogen, known as BUN or BUN, and creatinine. And so we can determine by looking at these things, as I showed you, you can kind of get an estimate. Okay, how fast over a period of time. So we can determine, we can estimate it with blood tests and urine tests, and we can exactly know about it by using other types of things that are there to look, and we can monitor disease and glomerular or all that good stuff. So here's what they use. These are the 24-hour urines. They use a substance, it's a plant polysaccharide. It doesn't have any impact to you. It's neither absorbed or secreted, so it doesn't impact you at all. It's kind of, you see the same thing. Think of it like an artificial sugar, we don't metabolize. Though some of them have some side effects, but some of the artificial sugars, I don't know that they found too many that don't. But years ago, they started with cyclamates and saccharin, and they had in different ways that theoretically you got the sweetness without getting the calories. So it's kind of the same idea. So the typical rate is about 125 milliliters per minute. So if it's less, resorbed. If it's zero, completely resorbed. If it's no net absorbed, that's the goal. If it's greater than, it was secreted. So effectively, you're able to monitor that. You have a certain dose you administer. You know how long it takes to clear. You assess it by collecting urine for 24 hours, and you get a reading of how much is in the urine. Because theoretically, it should have all been excreted, and you can do the math. Renal disease, when we start seeing somebody whose GFRs are under 60. So when I look at mine, I know that, and that's the way they judge it, 59 or less or 60 and over. So it's, and it's very qualitative. In other words, it's okay or it's not. That's what qualitative is. Yes or no. You're okay or you're not. Versus quantitative, which is what you're doing with the inulin. Nitrogenous waste, So look what happens. You don't get as much filtrate, waste materials accumulate, your acid-base balance goes towards acidic, and obviously acidic here. That's there. That's when we're looking at renal insufficiency. Once we get here, and that's the problem again, you have so many glomeruli. Once you get here, and you're at 15 mils per minute, what are you now? You're 8 plus time, 1/8 is effective. So like I said, you have probably, if you have 25% of one kidney, you would still be okay. But once you get below that, now your kidneys have failed. So sometimes it's very sudden between, just like you have to be on oxygen first, right? Now you have to be on dialysis, or you have to have a kidney transplant. Okay. So uremia is the first early sign, itching. That's one of the things when you see somebody whose kidneys are not doing well, they're just sitting there scratching at themselves, and then you get some aberrant behaviors. Why? My grandfather. Got a kidney removed because in the early days, sulfa drugs caused crystallization in the kidney, and lived to be 86 years old. So it wasn't, back then when it was like he died in 1976. Okay, and he had odd behaviors. Like, I mean, he was doing some very interesting stuff. God, very interesting guy. And so the treatment now, perhaps more transplant available. Dialysis is a little, you can do dialysis. People on dialysis in the early days, back then, I learned more about it 45 years ago or so. You're looking at life expectancy of maybe less than 10 years. Now, a whole lot more. So here's the urine itself. Urea from amino acid breakdown, the biggest single component. Uric acid, purine metabolism. And again, when we have problems with that, typically they're from metabolic problems associated with a disease we call gout, symptomatic hyperuricemia. Been around diagrams of it and people with swollen big toes in the Egyptian hieroglyphs. It's nothing new under the sun. It's a standard metabolic disease. Everybody says, oh, it's just a problem with your joints. No, I mean, it starts there, and then it can deposit in organs, heart. So it can be fatal if untreated. People die because we didn't have a way to treat gout. All they were doing was bleeding people and keeping them away from rich foods. They thought it was disease of the wealthy. We know that in most cases, it's an enzyme lack. Sometimes it's secondary to some primary kidney disease, different story. Creatinine, again, those are the big agents that we have to somehow get rid of. So other things, sodium, potassium, phosphate, sulfates, et cetera, et cetera. If it's not right, so when you do a urinalysis, typically the very first thing that they'll do is they dipstick. And what it's going to tell you, is there any blood? Are there any proteins that are there? Then you'll do a microscope. So you look at blood, proteins, pH. You're able to assess, roughly the concentration of it, whether it's hypertonic or not, by specific gravity. It's very, this is very straightforward testing. Then you do a quick microscopic. And then you're able to see, is it cloudy, which would suggest white blood cells. It should be clear. It should have the typical color. It shouldn't be discolored, because then you're starting to see breakdown. And Lord knows I'm too familiar with those. Okay? So all of those types of things we look for. Glycosuria, classic for diabetes. Proteins. Could be normal, physical exertion or pregnancy, or pathological problems with the kidney, other issues that are there, renal disease. So when we see proteinuria, wonder. Certainly, if you see anything that shouldn't be there, bacteria are interesting. Understand that anatomically, and if you all didn't, most of you, we all know what it's about. The anatomical differences between men and women, with the proximity of the urethra in the anogenital region of the female as opposed to the male, it's a lot harder to get clean catch, sterile, quote unquote sterile, or quote unquote clean catch specimen. In a male, it's easy. They'd wipe down with betadine, initiate the stream, catch, do a midstream, we call it midstream clean catch, cover it, okay, done. And a female, a lot harder to get that effectively. So it's not unusual to see transient bacteria or little bits of blood during menstruation or in close proximity to it. All of those things add into it. Okay? So just thought you're going to throw that out there. But in a male, if you see bacteria, something's up. In a female, you probably need to do some additional testing, or then you do we do what's called a colony count. In micro, did you do pour plates and a spread plate and do colony counts at all in a micro lab? Is that right? That's what you do. We do it on EMB because typically you're looking for E. coli and cousins because they're potent lactose fermenters, and EMB, it lights up like a Christmas tree if it's E. coli or the quote unquote coliform bacteria. If you can find out I know entirely too much about urine. I told you about the dog. We think it can't bow odor. Hanky panky, golden showers. Dog could be, different. I'm just saying. It's okay. I don't watch them. But you can watch them on those cameras. They do a lot of going there. Okay. Enough of that. That didn't get it. Now, ketones. Significant in diabetics who are not properly or sufficiently treated. They get ketonuria. That's somewhat ominous because now you're tending toward ketoacidosis. If you're dietary and you're doing a carbohydrate sparing diet like the Atkins or keto or South Beach, that's desired because you want to burn fats. You just want to make sure you can get rid of them sufficiently. So you have to hydrate like crazy with that diet. Okay? Hemoglobin. So it's a little bit different. Seeing some hemoglobin, whether it's a transfusion reaction, etc., versus what I unfortunately have entirely too frequently, other type things in it like hematuria, trauma, kidney stones, infections, cancer. So, and the distance between trace, which could be a urinary tract infection, versus frank or obvious or gross hematuria, which most of the time indicates if it's not trauma, cancer that are there. So hemoglobin, you could see from different things that are there, bile pigments with liver disease, white blood cells, it's almost always infection. So that just gives you, you learn a lot. Clear, okay, pale to deep yellow from urochrome, pigment from hemoglobin breakdown, very similar to bilirubin and stercobilin and urobilinogen that have a lot to do with both feces and urine. Anything abnormal, and sometimes it can just be dietary. Right? There's certain things, there's medications that can cause it, and they will tell you. See, do not do this for real. See, as an old chemistry major, you used to give people, I shouldn't say this, we made like little tablets out of methylene blue. And so they would go to the bathroom and it would be blue. We heard shrieks from the men's
You
room.
guys
We're evil.
yourselves with methylene blue.
Yeah. It's not going to impact you. Methylene blue, sterile methylene blue is what we use with the sterile scribe. I'd mark on it. We would mark our really cut bone with a methylene blue sterile surgical scribe or surgical.
So wait, how would you guys give them to each other? Like
Hey, here, they look like M&Ms. They kind of look like blue M&Ms. Like, here's some mini M&Ms. And I love M&Ms.
And you didn't realize, hey, this tastes like a mini M&M?
Yeah. Yeah, you got a bunch of chocolate in there in the other ones. Have you ever eaten just a tiny little one like that?
You guys make methylene blue tablets with blue M&Ms. You guys are different breed.
Yeah, you got to be careful with chemistry majors. We were weird.
Very
weird. Very weird. Strange people. Look at Dr. Badger.
I don't think Dr. Badger is drugging people with meth.
No. But he's heard about it. I'll bet. See, there's even medicines that come that way.
This candy jar one of these days.
We need to watch out. If you're going, all of a sudden it's blue.
Is that what you're referring?
Don't start shrieking. You'll also be red too. I mean, there's a lot of dyes that we use in the microwave.
You could use saffron.
You could use saffron.
You could.
Congo red.
Oh,
malachite green.
I'm a big malachite green fan.
I know. I love that stuff.
Oh yeah.
But for years, dyes they're antibacterial. We used to use crystal violet, which is known as gentian violet, methylene blue, and carbofuchsin, which in the old days we used topically for infection because they're highly antibacterial. Okay, and it was called Castellani's paint. That's the name of it. For vaginal infections, they used gentian violet, but they had a colorless form of it because purple would be a little disconcerting for people, if they were using it as a suppository or as a wash or something like that. That's the benefit of having we older individuals telling you about all that. Don't start. Gee, you're one of my two favorite advisees. The other one's also in the class.
What?
See, what? If you weren't on your phone,
I'm looking for something important.
This is important.
what's his name?
Just,
just.
It's about work. Actually.
Sure.
It actually is.
We wouldn't lie. Normally we don't pay attention, but this time.
Okay.
That is work.
I stand corrected.
See?
Don't doubt us.
Okay, more. So you can see all of these types of things that are there. Change certain foods do it. For people could tell if they were on penicillin, which a lot of it's excreted in the urine, asparagus, which I happen to like. If you get asparagus, and it's asparagus season now, try this if you haven't. If you snap the stems, the fibrous part snaps off with whole asparagus spears. Olive oil, salt, pepper, 425, about 15 to 20 minutes. Sheet pan, happy dance. Roast asparagus.
But you're gonna produce a cookbook.
There's nothing new with that cookbook. Everybody knows about that. So diseases, acetone, we have acetone breath, drugs and vegetables, slightly acidic, changes with your diet, okay? Specific gravity has to do, and that's one of the ways we can tell if it's got the right tonicity, if you will. And then lastly, this is anatomical, all those kinds of things. The physiological point is this. There are several things that make kidney stones, infections, bleeding, calcium. That's why you have to use the right calcium if you're using a calcium substitute. And typically, calcium carbonate works the best. We used to call it Oscal or oyster shell calcium. So it's not the only one. Uric acid in gouty patients. And so effectively, the smooth muscles induce spasm, and the calculi can be real problematic. Most of the time, they're not. Lithotripsy is a big help as opposed to surgery. Just like gallstones, hydration is important. So a word to the wise. We're seeing, it used to be, kidney stones used to be mostly in men who were younger when it first struck them in, let's say, in their 30s to 40s. We're seeing a lot more younger women with the problem. And I don't have an answer why. Maybe there's an abundance of eating the wrong type of calcium. I don't know. Maybe not as much hydration. The bladder, there's not much to it unless you're stupid and you smoke. Okay. And again, the advantage is it's got a wonderful muscle that's so thick it prevents a lot of cancer-like problems or infections from spreading. But the trouble with infections, what happens, again, ultimately it's a plumbing problem. And if you can't get out, like if I have a stricture now, if I would get an infection, it would back up the ureters into the kidney. Now you have real trouble. Okay. So all of that, and we'll get into this. We did the anatomy, the trigone, because it doesn't expand or contract that flat area is usually where we see infections. You see the rugae, and again, it can go from it can hold moderately full, be about a pint. What you do today in medicine, do you guys do that? Because you're treating mostly kids. Typically, they do urograms. They do an ultrasonic scan after somebody urinates to make sure that they've emptied sufficiently. For adults, we do that.
Bladder scanning?
Yeah, bladder scanning.
I did not.
Yeah, it's a good idea because a lot of times you're concerned, particularly if they were on a catheter, that there might be a problem with it, and that could lead to an infection. So it's got quite a bit of fill associated. This is the old days. We used to do this thing called an IVP, intravenous pyelogram. And what it would do, we'd have a dye. This is done differently. And it would outline the calyces, the kidney, the ureters. That was the test. I used to do a ton of injections. You had to inject people intravenously. And they do, now we have with MRIs and CTs, not as much. But in the old days, before we had that technology, when I was a resident before 1980, it was you'd inject them with certain dyes that would accumulate. Goodbye, everybody. Oh, the students who actually like me.
Do that every day.
Yeah.
You need a better joke. That one's getting old.
I'll think of something.
Okay.
Yeah. We'll get into that type of stuff because we're going to do the reproductive physiology thing that are there. Back pain and flank pain are the big indicators of problems. I think they're good for antibiotics. This is the physiology, and I'm not going into it with regard to that type of thing. There's so many problems that are associated with it. Again, I think it's more elderly than anything else that are there. Other types of thing, catheterization. And I think we did it. All right, everybody. We are in earnest going to start the I'm going to do repro. So next week we're only here 2 days. I'll try to get the male physiology is a little easier than the female physiology. So we'll get the male on Monday, probably start the female Wednesday, and finish it on the flip side, maybe on the Monday the 10th. We come back after the break, and then then it's going to be at that point. We're going to start looking at some additional selected topics that are there. I do like to do a developmental unit, which I did with the MCAT people. I do the growth and development from the early days, the in utero. I try to stay away from the aging. It's getting too personal.
That was a good one.
Thanks a lot.
I don't doesn't mean much coming from me, but
It's all right.
I respect it.
I thank you. All right, I'm moving on. Goodbye. Thankfully, Dr. Buxton and I will be very happy because soccer is back.